So starting with our first question, we have a 28-year-old patient who presents with productive cough over last 5 days. He has fever and also some breathing difficulty on exertion in the past 2 days. Observations are as given. On examination, sputum is green colored. There is some reduced air entry on the left lower base, and then you hear some crepitations. Sputum culture grows positive gram-positive diplococci. What is the most likely organism? So we can start the polls. All right. Give it a few more seconds. Okay, ending the poll. So yes, most of you all have chosen B. B is the right answer. It's Streptococcus pneumoniae. If you see the question carefully, it is a classic presentation of pneumonia caused by Streptococcus. The thing that some of you might have got confused with here was between options B and C. I see that the second most chosen answer was C, Staphylococcus, but it's not the most likely organism. Green colored sputum, it is also the most likely answer in this case. Staphylococcus aureus, you see a lot of cases in alcoholics, so that if the question says that the patient is a known alcoholic, then maybe your answer can be a Staphylococcus, but it's always Streptococcus when it's the most likely organism asked. So strep pneumoniae. So diagnosis is community acquired pneumonia or CAP. You have your differentials, which is exacerbation of COPD, but the question does not suggest that the patient has a background of COPD. So this is unlikely. Atypical pneumonia doesn't present with a productive cough. It's usually a dry cough and pyrexia. So that is unlikely in this case. Aspiration, in terms of a patient who is well and doesn't have a background of, say, stroke or any swallowing abnormalities, any dysphagia, then aspiration is unlikely. So in this case, the patient doesn't have any of those risk factors for aspiration. Heart failure is again unlikely. He's quite a young patient and he doesn't have a chronic history or any other feature suggestive of heart failure or pulmonary edema. And tuberculosis is a longer period of symptoms. So it will be over a few weeks or months. It won't be an acute presentation. So that is, but you have to keep all these differentials in mind. Points in favor in this question will be the fever, of course. Then you have the productive classic green colored sputum. Auscultation sign, so there was reduced air entry in the lung base and a positive sputum culture, of course. In terms of investigations, when you do bloods, you will find the inflammatory markers are raised. Chest X-ray will show consolidation or collapse. If you see the chest X-ray alongside, there is a patchy consolidation over the right lower base. So that is again a feature of pneumonia. Management, it depends on the patient's condition. If the patient has stable OBS, he can be considered for oral antibiotics and managed at home. But if the patient looks unwell, then we need to consider IV antibiotics, admission to hospital, IV fluids for hydration, and chest physiotherapy to improve the expansion of lungs. So next question. A 19-year-old football player suddenly collapsed during a match. He was found to be short of breath and complained of right-sided chest pain. His observations, he's apyrexial. The observations are given. On auscultation, there is no breath sounds on the right. What is the most likely next step? You can start the polls. A few more seconds. Right, ending the polls now. So most of you all have chosen D, needle thoracocentesis on the right side. Very good, it is the right answer. The scenario is an emergency. It is outside the hospital if you observe. So at some point, the patient will need a chest drain, but the next likely step in this scenario is a needle thoracocentesis to relieve the pressure. And it's on the right side because you see the symptoms. The patient has a right-sided chest pain and no breath sounds on the right. So it's going to be needle thoracocentesis on the right side. Bear in mind that pneumothorax is a clinical diagnosis, so you might not have a chance to verify your diagnosis with an X-ray, especially in a outside hospital setting. So there is a diagnosis is tension pneumothorax in this case. So points in favor of diagnosis are sudden onset. It's non-traumatic. So he was playing football and that's when he developed sudden onset of shortness of breath. The dyspnea with or without chest pain. Then there is a cardiovascular compromise happening. So if you see he is tachycardic, blood pressure has started to drop. It's borderline now. The respiratory rate has gone up and the SATs are dropping as well. So there is some amount of cardiovascular compromise here and the absence of air entry on affected side that you hear on auscultation. So all this together brings you to the diagnosis of tension pneumothorax. If the patient is stable, you might, and the patient is in the hospital, you might want to consider a chest X-ray. In that case, if you look at the chest X-ray, there is absence of vascular markings on the right side. So when the organs are paired, always compare with the opposite side. So if there is a pair of lungs. On the right, you see that there are no vascular markings. On the left, you will see all the vascular markings going right to the end. So it's the right-sided pneumothorax here. There's lung collapse. So there is a thin white border that you see, which is of the lung on the right side. So, and the darkness is the shadow for the air space, air in the pleural space. And the trachea can be deviated to the opposite side because of the air accumulation. In terms of management, in an emergency setting, you do needle thoracocentesis, and that happens in the second intercostal space, mid-clavicular line. And the next step is to transfer the patient to the hospital as soon as possible. So relieve the patient, transfer to the hospital. And then in a hospital setting, you put a chest drain in the fifth intercostal space, anterior axillary line. And you need to treat the cause if it is persistent. For example, if a patient has a chronic obstructive pulmonary disease, so your COPD, so if the lungs there are a lot of bullae which are rupturing and that's causing persistent pneumothorax, you might want to consider a bulectomy at some point. Okay. A young motorcyclist presents to A&E with sudden onset shortness of breath. Going through his records, you realize he was discharged a week ago after undergoing a surgery for a fractured femur. His past history is unremarkable. He was fit and well otherwise. Obs are given, and you perform a chest X-ray. So what is the most likely diagnosis in this case? Give you a few more seconds to answer. Right, ending the polls. Okay, so most of you all have chosen D, pulmonary embolism, which is the right answer. In this case, fat embolism is unlikely because the patient has already been operated for his fractured femur and already a week has passed before his discharge, after which he was discharged. So fat embolism is unlikely in this case. So the diagnosis and all the findings point towards pulmonary embolism. So it is sudden onset. There is a recent history of surgery in this case. So there is some amount of reduced mobility, you can say. And then there is tachycardia with dropping SATs. So heart rate of 100 and 92% on air. So that means that there is some amount of cardiovascular compromise here as well. In terms of investigations, if you do an ECG, you might see an S1Q3T3 pattern, although it's quite a rare thing to find this on an ECG. So if you see the ECG that is on the side, in lead 1 you will see a deep S wave, and in lead 3 you will see a deep Q wave and an inverted T wave. So that's your S1Q3T3 pattern. If you do bloods and you do a D dimer, you will find that it is raised, but it is non-specific. A chest X-ray will appear normal in for most cases of pulmonary embolism, but we need to keep that as something to rule out other causes. Definitive investigation is a CTPA, but that's not for fat embolism. So CTPA is for a pulmonary embolism. And if there is any signs of DVT, you can do a Doppler of the leg, which will confirm a DVT. So CTPA, if you see the CT shown on the screen, there is a thick thrombus seen in the bifurcation of the pulmonary trunk. So that's the clot embolus seen in a pulmonary artery, which will be seen in CTPA if there is a massive pulmonary embolism. For massive pulmonary embolism, you have to do the imaging within 1 hour, but the imaging should not delay your management if there is a strong suspicion for PE. So your treatment will go as thrombolysis. So you can either give an alteplase bolus if there is a massive PE. So this is recommended by VTS, British Thoracic Society. Or if it is not a massive PE, but there is still a suspicion for PE while you're waiting a CT scan, you can start with an unfractionated heparin or a low molecular weight heparin infusion. And when there are recurrent PEs in the same patient, then you would want to consider an IVC filter to avoid all the clots from the legs going into the lungs and causing the PE. And there's a link for the BTS management of acute PE at the bottom. Okay, next question. A 40-year-old woman undergoes esophageal dilatation for long-standing dysphagia, secondary to a benign peptic stricture. She develops sudden onset breathlessness and starts feeling unwell. Her OBS are stable except for a rise in respiratory rate. And what is the most likely chest X-ray appearance that you see? You can start the polls. You all are very good and very quick and spontaneous in answering. And I see that most of you all are answering correctly, which is very good. Okay, so I'll end the polls now. All right, so most of you all have chosen B as the answer. So free mediastinal gas. In this case, you see that there was an esophageal procedure going on. And because esophagus is a hollow organ, whenever there's a perforation, there is air escape, and the air from the esophagus will escape into the mediastinal space. So that's why there will be free mediastinal gas that you see. If you see the chest X-ray carefully, there is a line overlying the heart border on the left side, and there's a thin black line under it. So that's the presence of air in the mediastinal space. Okay. So pneumomediastinum. The diagnosis is esophageal perforation. So iatrogenic is the leading cause of esophageal perforation, which is what happened in this case. So there is sudden onset. It happened during a procedure. Tachypnea and the chest X-ray findings all together are in favor of pneumomediastinum. So chest X-ray findings, pneumomediastinum in this case, if it persists, it can also go up to form subcutaneous emphysema. And initially it will start around the thoracic wall and then slowly advance into the neck, which is not good at all. Mediastinal widening will be seen, and there will be some air fluid level in mediastinum. It will be seen better in a lateral X-ray, the air fluid level. So investigations, if you're suspecting subcutaneous emphysema which has advanced towards the neck, you will have to do a neck AP and lateral view to confirm that. Or a subcutaneous emphysema in the thorax, you do an AP lateral view of the thorax. If you want to find where exactly the defect has occurred, there will be a barium study which you can perform, which will accurately point out where the defect lies. In terms of management, the patient has to be kept nil by mouth. Then you maintain hydration by giving IV fluids, IV antibiotics to avoid for prophylactic antibiotic treatment, analgesia. And obviously, if the patient is nil by mouth, you can't supplement everything by just providing IV fluids. So the patient needs a strict feeding regimen. So that will be total parenteral nutrition. And then you have to decide between operative and non-operative management depending on the defect, the location of the defect, and if it can be treated conservatively or no. So let's revise some mediastinal anatomy. So you have your superior mediastinum and inferior mediastinum. The superior border of the superior mediastinum, it is an oblique plane. So if you look at the picture alongside the green part, it's an oblique plane which joins the jugular notch and the superior border of T1 vertebra, and the lower border, which is the line between the superior and inferior mediastinum. That's a transverse plane from the angle of the sternum to T4, T5 intervertebral disc. So that will be your superior mediastinum. Your inferior is divided into anterior, middle, and posterior. The anterior mediastinum is bounded in front by the body of the sternum and posteriorly by the pericardium. The middle mediastinum has the heart and the great vessels which arise from it. And the posterior mediastinum is everything behind the heart, but not including the vertebra. So a lot of questions where there's anatomy, you'll have the vertebra as one of the options when they're trying to test the posterior mediastinal contents, or even the superior mediastinum. They might put thoracic or vertebra in the options. So the vertebra are not a part of the mediastinal contents. Okay, so this is just a table summarizing all the contents of superior, inferior, anterior, middle, and posterior mediastinum. So we can go through it quickly. Organs in the superior mediastinum, you have the thymus, the trachea, and the esophagus. You have the blood vessels, so arteries and veins and lymphatics. So you have your aortic arch, the brachiocephalic trunk, and left common carotid and left subclavian. Veins and lymphatics, you have your superior vena cava, brachiocephalic vein, and the thoracic duct. And you have your nerves. So you have all the nerves passing through the superior mediastinum. That's your vagus, phrenic, left recurrent because it loops below and then goes back up. Compared to the right, it's the longer one. And you have your cardiac nerves, middle inferior mediastinum. Anteriorly, you will have the thymus, but then the thymus regresses, so it disappears by the time in adults it disappears. Basically, it goes smaller. In the middle mediastinum, you have heart and pericardium, and then you have the aorta, ascending aorta, the pulmonary trunk, and the pericardiophonic arteries. Veins and lymphatics, you have your superior vena cava, esophagus vein, and you have your pulmonary veins and the phrenic nerve. Posteriorly, you have the esophagus, the thoracic aorta, and you have the esophagus vein, which then gets connected by the hemiesophagus vein, and you have the thoracic duct and the vagus nerve. So phrenic lies just beside the heart. There's a likelihood of it getting damaged in cardiac procedures, and then post-operatively you will see that whichever side is damaged, the hemidiaphragm gets raised because there's no motor supply there. So phrenic is something you need to be careful in terms of middle mediastinal contents, and vagus is for posterior. Okay. A 55-year-old woman presents to A&E with severe wheeze and persistent dry cough. She says it started a few hours ago when she was hoovering the house. Past history, she has an asthma, hypertension, and hypothyroidism. She takes regular steroids. Her OBS, apyrexial, you have the OBS given. She's unable to complete sentences while providing you with a history. On auscultation, you hear widespread rhonchi all over. And then what is the most appropriate immediate management in this case? Yeah. Okay, a few more seconds. Right, ending the poll. Okay, so A has been the most selected answer. Well done. So this is a case of acute asthma. So you nebulize with salbutamol and ipratropium. It's acute exacerbation of asthma. So there are some triggers like dust, pollen, weather in itself, change of weather can be a trigger, and exercise. In this case, points that are going in favor of the diagnosis. So there is a wheeze, there's dry cough. The patient is a known asthmatic. There is a trigger. So she was hoovering the house. So there was possibly a dust, which was the cause of cause of asthma. Then there's tachycardia, dropping sats. There is an audible wheeze. And when you auscultate, you'll hear widespread rhonchi. And the thing that differentiates between a mild to a moderate asthma is the fact that she's unable to speak in full sentences. So she's unable to complete sentences while providing a history. It's a red flag. You need to bear this in mind, because that is going to change your management. If everything was all right, she was stable, and only wheeze was the issue, she could have been managed at home. But because she's unable to speak in full sentences and she has this dropping sats, we need to keep a close eye on her. So investigations, you'll do a chest x-ray. So that will be for your differentials. And when the patient is stable, you'll have to consider a peak expiratory flow rate. So that if it lies between 33 to 50% of her baseline, then you can confirm that, okay, fine, then that's an asthma. But that's only when the patient is stable, not in this case. Management wise, you will give high flow oxygen. So in asthmatics, your target oxygen sats should be more than 94%. So because she has already started dropping her sats, you need to support her with oxygen. Then you need to open her airways, so salbutamol and ipratropium. You can either do a back-to-back nebulization, or you can do a continuous nebulizer. She will require initiation with oral prednisolone. So although she is taking oral steroids at home, you might have to up her dose. So if she's taking 5 milligram maintenance dose, she'll have to go back to 30 milligram. So that's 6 tablets of 5 milligram. And if she's unable to take oral steroids, you'll have to give her IV or IM steroids. So your IV hydrocort or IV methylprednisolone. If still after all this basic management she doesn't improve, then she will have to be escalated to ITU. And when she's stable, a respiratory nurse referral should be made. Okay. So next question. A 58-year-old woman presents with worsening shortness of breath over last few hours. Her past medical history reveals mitral stenosis, diabetes, which is diet controlled. She's not on any regular medication. Her OBS are given. There are widespread crackles bilaterally, and she has a displaced apex beat and a systolic murmur. You start her on oxygen and perform a chest X-ray. What will be your next management plan? So starting the polls. Right, a few more seconds. Ending the polls now. Okay, so most of you all have chosen IV furosemide, which is the correct answer. If you look at the chest X-ray carefully, it's all very hazy throughout on both the sides. And given her history of, given her cardiac history of mitral stenosis, and the fact that you are auscultating crackles bilaterally, there is also a displaced apex beat and a systolic murmur. So all of this, and also a new requirement of oxygen, all of this together will go in favor of pulmonary edema. So you give IV furosemide for now. You have to offload the patient. So IV furosemide. How do you come to the diagnosis? The patient has mitral stenosis. So all the blood that is in the left atrium is not going into the left ventricle. So basically there is a clogging, and that's why there's pooling of blood in the pulmonary system and there's pulmonary edema. So gradual worsening, that's something which is important. So the other cases which we discussed earlier, they all had sudden or acute onset. In this case, it's a gradual worsening. Then she has a mitral valve disease. There's cardiovascular compromise, and the widespread crackles and chest X-ray findings are pointing towards a pulmonary edema picture. If you ask the patient, she might also tell you that she is not able to lie flat. She requires some amount of pillows. So, I mean, she goes out of breath when she tries to lay flat in bed. So orthopnea is another important finding. Investigations, you do your arterial blood gas and send some bloods. Chest X-ray as you can see, it has bilateral fluffy opacities. Echo will give you an idea of her left ventricular function and valvular abnormality. So you'll obviously see the mitral stenosis in this case. And if there's any other abnormality which is also contributing to this picture, you can find out on an echo. And management, you have to offload with IV diuretics. So because you're giving her diuretics, you have to monitor urine output, the renal function, and daily weights, because diuretics, if they are given excessively, it can dry the patient. So we also need to keep a watch on their weight. Monitor the blood gas, and if it's not improving, then you might need to consider escalation. So she might require some non-invasive ventilation if there's no improvement, or if she's progressing to a respiratory failure type picture on her blood gas. So that's when you escalate to ITU. Okay. An 80-year-old man was brought by his daughter due to progressively worsening shortness of breath over the past week. He was apyrexial, but his mobility was greatly reduced to dyspnea. He is an ex-smoker and worked at a cement factory. Obs are stable. On examination, there's right side reduced entry mid to lower zone, and you perform an ABG and a chest X-ray is given alongside. Which of the following do you think is correct? So you have the ABG findings and you have the chest X-ray on your right. So let's start the polls. Yeah. Okay, few more seconds. All right, ending the polls now. All right, so E was the most chosen answer, which is correct. Let's look at the blood gas. pH, alcohol, right? Then you have your PCO2, which is low, normal range. So this is an acute picture, and you will see that it is respiratory alkalosis. Also, clinically, this patient is dyspneic, so he's trying to remove or wash out his carbon dioxide, which is also going in favor of what we see on the ABG findings. So there is a low carbon dioxide because he's dyspneic and he's tachypneic and he's washing out all the carbon dioxide. And on the chest X-ray, you will see on the right side, there is a horizontal line and there is blunting of the costophrenic angle. So there is a clear pleural effusion on the chest X-ray. Okay. All right. So points in favor. This is again a progressively worsening condition. There is reduced exercise tolerance. Occupational hazard. So he's an ex-smoker and he worked at a cement factory. So that is an occupational hazard in this case. Auscultation and chest X-ray findings and the ABG, all of them point towards a pleural effusion with a respiratory alkalosis. So in patients who are who have some background of working with in a factory or some construction work, then there is some amount of asbestos exposure that happened in the past. So a mesothelioma should be at the back of your mind. And otherwise, the other finding is an infective etiology. But we will find out when we send the pleural fluid sample for testing. So on the chest X-ray, you see right-sided pleural effusion. And management-wise, pleural fluid drainage and analysis. It's a lot of pleural fluid here. So you have to drain it to improve the patient's symptoms. And you have to send those samples for checking whether it's an exudate or transudate, and also for cytology and microscopy for culture and sensitivity. So that will be giving you an idea of what might be happening. If the pleural fluid is persistent, it keeps collecting after multiple drainage attempts, then a pleural biopsy for a suspected mesothelioma should be considered, and that should be sent for histopathology. And you can give the patient's IV antibiotics if you see signs of patient becoming unwell, or patient is septic, or patient starts spiking her temperature. Then you would want to send IV, you would want to start the patient on broad spectrum IV antibiotics, awaiting culture results. So exudate versus transudate. In terms of transudate, what are the possible causes? So you have congestive heart failure and renal issues like nephrotic syndrome. Transudate is also seen in liver cirrhosis, and PE can cause transudate accumulation in the pleural cavity. Exudate is infective etiology or malignancy. So your infections like pneumonia, TB can cause an exudate. Malignancy of the pleural space can cause an exudate. And connective tissue disorders or other abdominal disorders, they are rarer causes of exudate. Chylothorax is another thing. So mostly chylothorax can happen if there is a blockage in the lymphatic duct anywhere, or iatrogenic cause of chylothorax during a manipulation in the thoracic cavity. If there is a sudden, because the thoracic duct lies quite close to the mediastinum, so there is a likelihood of it getting damaged and a chyle leak. So chylothorax can be a cause of exudate. So we have the Lights criteria for transudate and exudate. It depends on the protein content, the LDH in the pleura and the serum, and the causes as we have discussed. So high protein and high LDH will go in favor of an exudate over transudate. All right, a young man presents to his GP with symptoms of severe cough at night. He says he hasn't slept in the last few days due to this and is unable to work during the day. You look at his past medical history, and he's a known asthmatic, takes regular high-dose inhaled steroids and salbutamol when required. Which of the following medications will benefit him? Yeah. A few more seconds. Ending the poll. Okay, so most of you all chose E, inhaled long-acting beta-2 agonist, as the answer. But in this case, the answer is A, because there is only nocturnal symptom in this patient. So, one second. Yeah. So leukotriene receptor antagonist or montelukast for nocturnal symptoms. So you'll do, because the patient is stable, you can do a peak expiratory flow rate and a chest X-ray just to rule out anything else causing his symptoms. And this is the guideline that I found from British Thoracic Society. So you start with a low dose inhaled corticosteroid, and the top, so that will be your maintenance. and then a top up of salbutamol as required. But in this case, the patient is already on increased dose of inhaled corticosteroid. So in that case, you have to add a leukotriene receptor antagonist. Yeah. So that's why the answer is montelukast. If it was daytime symptoms which were not controlled, then you might want to consider a LABA. But LABA doesn't always give the response that you want. So quite a few patients end up having to stop their LABA. So that's why you add a leukotriene receptor in this case, for nocturnal symptoms especially. Okay. A 66-year-old man with a known history of emphysema is brought to A&E by ambulance. He's acutely breathless and can barely speak. He has a respirate of 40 and a pulse of 130 beats per minute, blood pressure of 80/60. Air entry is poor on the left and inaudible on the right side. There is hyperresonant percussion on the right, and his trachea is deviated to the left. What is the single most appropriate immediate action? Few more seconds. Ending the poll now. Okay, so between B and D, I think there was some confusion. If you read the question carefully, the patient has already been brought to the hospital. So we have all the resources to insert a chest drain in, which will be for a longer term. Rather than sticking a needle in him twice, we can just insert the chest drain and monitor him. So inserting a chest drain in the right pleural space is the right answer here. So he has a background of emphysema. Oh, sorry. No, it's the chest drain. Sorry, my bad. The answer over here I have written as white bone needle. It's a chest drain in the right pleural cavity. So diagnosis is a spontaneous pneumothorax. He has a background of emphysema, so there is a possible bullous rupture. It's an acute onset episode, and patient is unable to speak, which is quite alarming. Trachea is deviated, which you would see if there is a massive pneumothorax. Absent breath sounds on the affected side, and hyporesonant percussion. So if there's air in the pleural space, you'll hear, you will be able to percuss hyperresonant note, and there's a cardiovascular compromise already happening. So it is an emergency. You have to insert the chest drain to relieve the air in the cavity. So investigations, pneumothorax is on the right if the patient is stable, but in this case, it's better to manage given that clinically you are sure that this is a pneumothorax. You can do a blood gas to check the perfusion, and a CT scan to check extent of the disease when the patient has been stabilized. So you'll know how bad his lungs have actually become from his emphysema. Management, hospital management. So you do chest drain insertion in 5th intercostal space, anterior axillary line, and then you have to do an underwater seal. So you'll be able to monitor the air leak. Once the air leak is very minimal or absent even on coughing, that's when you know that the chest drain can come out. And then you also have to do a repeat X-ray to see if there's any collapse after you've removed the chest drain. If you do a CT scan or if there is a persistent pneumothorax, then you would want to consider billectomy at this point. Okay. A 2-year-old child was brought in by a worried mother because he was not behaving usual. She said he felt warm to touch few hours ago and was given Calpol. He gradually looked more unwell and she noticed some drooling of saliva. On examination, the child looks toxic. He's not interactive. Obs are given. You notice an inspiratory harsh sound and a drooling of saliva. Which of the following is the most likely organism causing the picture? Okay, few more seconds. All right, ending the poll now. So B is the right answer. Well done. So anyone can guess the diagnosis? Yes, it is epiculotitis. Well done. Yes. So quite a few red flags which are pointing towards this diagnosis. Number one, the patient is pyrexial. And usually when a mother is very worried about her child coming in with pyrexia, which is not settling after giving Calpol, or the child behaves unusual, then there is something that needs to be investigated. So the child looking unwell and there is drooling of saliva, which are two red flags here. Looks toxic when you examine the child yourself and is not interactive. So 2-year-olds are very active. So if the child is not interactive and is very silent, keeps to himself, then there is something wrong. Obs wise, the obs are, except for the temperature, the rest of the obs are normal for this age group. So it's not that the child is in shock or something. So blood pressure is in the normal range. The heart rate is high for a 2-year-old. Respirates is high for a 2-year-old, and the SATs are normal. So what's the inspiratory harsh sound that you can hear? Does anyone know what it's called? Yes, it is stridor. Very good. And there is drooling of saliva. So it is a bacterial cause here because there is systemically the child looks very unwell. So it's not parainfluenza. Strep pyogenes and staph aureus are unlikely in this case, given the fact that um, if there was a strep or staph infection, it would be a lung issue rather than an upper respiratory tract issue. Or when you examine the throat, you will see some tonsillitis kind of a picture if you suspect a strep or staph. Candida albicans, there is no low immunity status. So immunocompromised individuals are more likely to get Candida albicans. And in this case, all the other picture, and the patient won't be as septic as this one. So Candida albicans is also unlikely. Okay. So you have your acute epiglottitis. The child will be in a classic tripod position with outstretched arms, leaning forward with a protruding tongue. So that is basically something that is obstructing his upper airway. He's trying to relieve it because your gravity will open up the airway if the tongue is protruding, patient is leaning forward. So you let the child be in that position. Then you remember the 4 Ds. There's dysphagia, there's drooling, dysphonia. So dysphagia, the child will not be eating anything. So reduced appetite, there's drooling. The child is visibly in distress and there's dysphonia. So the child doesn't speak, no interaction. Points in favor. In this age group, acute epiglottitis is seen. So it's a 2-year-old. So up to 3 to 5-year-old, you can see acute epiglottitis type picture. High grade fever, a toxic look, drooling, and stridor all point in favor of epiglottitis. It's a clinical diagnosis and a medical emergency, so it needs to be managed quickly. Bloods will show raised inflammatory markers because it's a bacterial condition or an infective etiology. If the patient looks stable, then you might want to do a lateral soft tissue neck x-ray, which will show your epiglottitis. So if you see the chest x-ray and the arrow pointing towards the epiglottis, it's enlarged in this case. You have your hyoid bone, and then you have the epiglottis, which looks visibly enlarged. Management, you start the patient with IV antibiotics. Patient needs hydration because of the dysphagia, there is reduced feeding, so IV fluids. If he doesn't improve, you might want to escalate and intubation to secure the airway. If intubation is difficult because if the epiglottis is quite enlarged, you might not be able to pass an ET tube in. So you will have to do an emergency tracheostomy if the condition worsens. And a 50-year-old known alcoholic patient is admitted to the hospital with acute pancreatitis. He's managed conservatively. On day 2, he is noted to have stenosis, tachypnea, and tachycardia. On auscultation, there are bilateral crackles on his inspiration. ECG is unremarkable, and you have the chest X-ray findings. So what is the most likely diagnosis? Yeah. Okay, few more seconds. And ending the poll now. Okay, so C was the most chosen answer, acute respiratory distress syndrome. Yes, that's the correct answer. A lot of y'all have also chosen hospital-acquired pneumonia. I think the day 2 was a bit confusing. In this case, hospital-acquired pneumonia is also likely, but if you see he has a background, he's an alcoholic with a background of acute pancreatitis, and for hospital-acquired pneumonia, there will be other signs and symptoms. He might have fever or a cough, something which supports a pneumonia picture. But in this case, he's cyanotic, tachypnic, tachycardic with a background of acute pancreatitis and bilateral crackles on inspiration, which is there throughout. If you see the chest X-ray, it's widespread on both the lungs. So it's a bit unlikely for hospital-acquired pneumonia to be that widespread in the initial stages. So it's ARDS in this case. The other differential which you might want to consider is a cardiogenic pulmonary edema because the chest X-ray looks similar. But because there are no cardiogenic findings, the patient doesn't have a background of any cardiac issues, any cardiac history, an acute cardiogenic pulmonary edema, unless the patient has been overloaded with IV fluids while trying to conservatively manage his pancreatitis, it's unlikely for him to go into pulmonary edema from a cardiogenic cause. So that's not going to happen in this case. Pulmonary TB is again a prolonged picture. And atypical pneumonia will again have fever with a dry cough or something which points towards a pneumonia. Yeah. Yeah, so ARDS points in favor of diagnosis. You have acute pancreatitis, which is being managed conservatively, acute onset of respiratory symptoms, auscultation findings, and a chest X-ray. So you have to remember that ARDS is a non-cardiogenic pulmonary edema, and it results from an acute lung injury or secondary to a systemic illness. So in this case, you have acute pancreatitis, which is causing your pulmonary edema. So other causes are your pneumonia can cause pulmonary edema, acute respiratory distress syndrome. Aspiration pneumonitis can cause ARDS. Inhalation injury can cause ARDS. Shock sepsis can cause ARDS. Liver and pancreas, so liver failure or an acute pancreatitis, like in this case, can cause an ARDS. Other less likely causes are amniotic embolism. Investigations, you do your routine blood, so FBC, use an A's liver function test, do your amylase, clotting. Also, if you have diagnosed pancreatitis, you might have an amylase from day one. So you can see the trend of amylase in this case, whether it's going down or you need to do something else for it. Check your clotting. So your DIC can be ruled out, and your CRP to see if there is any inflammatory or an infective etiology. Chest X-ray will show bilateral infiltrates, which are seen on this X-ray. Your blood gas, and you do a pulmonary capillary wedge pressure, PCWP. If it shows that it's less than 19, that means you can safely rule out a cardiogenic cause. So patient is not overloaded. This is an ARDS causing the picture that we see. Management is admission to ITU. So if the patient is being managed for pancreatitis on the ward, he might need escalation to ITU, and a CPAP with 40 to 60% oxygen for respiratory support. Patient will also need circulatory support, so you need to maintain the cardiac output with inotropes. If the patient gets septic at any point, you need to do your sepsis 6 and send cultures, start the patient on broad spectrum antibiotics, and nutritional support in this case. Okay, so this is a quick tabular revision for all of you for shortness of breath. So these are the main acute shortness of breath differentials that you would like to consider. So pneumonia, pneumothorax, pulmonary embolism, your pulmonary edema, acute asthma, exacerbation of COPD, and a pleural effusion. So based on what we have discussed today, the symptoms, on the signs that we see, the investigations that we need to consider, and the management. So everything is, I've put everything in one concise tabular form. The other thing to keep in mind is pneumonias can be atypical as well. So your most likely organism strep will cause strep, or staph will cause a productive cough. But when the pneumonias are atypical and you see those patchy consolidations, then you might want to consider other causes. So you have mycoplasma, Legionella, pneumocystis, and Cetacea. So these are the other causes. So for mycoplasma, it presents similarly to your other cap, most likely organisms, but if you see the management is different, your first line will be clarithromycin, unlike an amoxicillin or amoxiclav that you would start. For Legionella, it's the same, but there will be a background of the patient coming from a vacation, or patient used air conditioners for a very long time, swimming. So you have Legionella at the back of your mind. For pneumocystis, there is a patient who comes with an immunocompromised state. So HIV or other risk factors will be mentioned, and there will be some interstitial shadowing. In this case, you manage the patient with cotrimoxazole. And for Cetacea, there will be some contact with pets or birds, and then tetracycline or clarithromycin. So these are, although not very commonly found, but their management is different. So you need to keep this in mind as well. So dry cough and fever should point more towards an atypical picture of a pneumonia. Okay, thank you very much for today. And that's the feedback QR code. I will answer your questions now. Hope that was helpful. So for a pneumothorax which develops in hospital, would you go straight with the chest drain or still do the needle decompression? Usually we just go with the chest drain, because why do you, if the patient is in a hospital setting, why do you want to prick the patient twice? So you do a needle decompression and then you do a chest drain. Again, you have to use the scalpel and local anesthetic and all of that. So if it's in a hospital setting, it's safer to do a chest drain. You can also monitor how much air was in the space, and that'll actually give you an idea of how big the pneumothorax or lung injury might be. In case 2, can't we suspect a PE? So we need chest x-ray instead of suspecting a pneumothorax. Just a minute, going back to case 2. So a PE in this case, just 1 second. If you see the auscultation findings, there's no breath sounds on the right. That is a big pointer towards a pneumothorax. In PE, you won't, you will be able to auscultate breath sounds. It will not be an absent unilateral breath sounds or bilateral breath sounds. So in this case, that is one thing that was actually pointing more towards a pneumothorax. And also he's a football player, so he's quite athletic, and the chances of him having a DVT which has caused a PE is very unlikely. So that's another thing. Okay. Would a fat embolism happen soon after surgery? Yes. So not after surgery, it happens soon after the trauma, because after the trauma you have the long bones, which have those the lipid molecules which can escape into the bloodstream. That's immediately after surgery. If you see patients developing these symptoms which are similar to a pulmonary embolism, then you can think of fat embolism. But in the third case, it was quite a long time. Even after the patient was operated upon, 1 week he was in the hospital, and then he developed this after being discharged. So that's pointing towards a pulmonary embolism, also because of his reduced mobility post-operatively. So why salbutamol and ipratropium instead of steroid nebulizer? It's an acute scenario. You start with step 1, which is salbutamol and ipratropium, something that's going to relieve immediately. Steroid nebulizers we don't usually give. You start with salbutamol, ipratropium, and steroids will be given for maintenance as oral or IV IM, depending on how the patient is compliant. But we want to top the patient's oral steroids up, but give salbutamol, ipratropium immediately. And that will be nebulizers. The patient will be taking inhalers at home. So nebulizers are more effective, especially if they are continuous nebulizers mixed with oxygen. So that will help in opening up the airways that have collapsed. So you would want them to work quickly. All right. Thank you very much, everyone. Any more questions? Yeah, I will go back to that table. So if you look at this, the guideline, when you start the LABA, initially you start the patient on low dose inhaled corticosteroids. And if the patient is still having recurrent attacks of asthma, that means you need to improve the preventer medication. So you give an inhaled LABA, you add it to a low dose inhaled corticosteroid. But in our case, the patient has already gone to an increased dose of inhaled corticosteroid. So patient was on the high dose of inhaled corticosteroid. So you can't go any more up in that. And the patient has nocturnal symptoms. So LABA is usually given for daytime symptoms, which are persistent or not, you're not able to control them with the corticosteroid. That comes as a combination. In this case, if you see, he's already on the third step. So he's already on increased inhaled corticosteroids. That's why you would want to add a leukotriene receptor antagonist. And in this case, with the nocturnal symptoms, that's going to be more beneficial. Respiratory alkalosis, yes. Yeah. So if you look at the ABG findings, your pH is 7.48, so it is going up. So going up means it's alkalosis. Now you need to find out whether it's metabolic or respiratory. If it's metabolic, your bicarbonate is an alkalotic substance in the blood. It will go up if it is causing alkalosis. Carbon dioxide is an acidic gas. So if it is going low, that means there is alkalosis, but on the respiratory side. So in this question, in this table, if you see, the pH is 7.48. So that's going up. You know it is alkalosis. Look at the PCO2. Your carbon dioxide is an acidic gas. It's going down. And your bicarbonate is in the normal range. So you know it's not the metabolic component causing the alkalosis. That's why it's a respiratory alkalosis in this case. And also, if you look at the picture, whenever the patient is tachypnic and it's acute, he's going to wash out all the carbon dioxide that's being generated more quickly than you normally would. And carbon dioxide being an acidic gas, if you're throwing up all the acid, it's going to be alkalosis when you check the blood.